Hello everybody, I'm Dr. Deeksha Pandey and once again you are watching Urogynecology for Beginners. Today we'll discuss about fibroids and urogynecology. Fibroids being one of the most common lesions what we see in our gynecological practice, how this fibroid can cause urogynecological problems. So there are 5 kind of problems we can have once a patient presents with fibroid. The first and the most common among those is when a lady had fibroids in her posterior wall of uterus. What it does is these fibroids pull the uterus down towards the pouch of Douglas so that the cervix starts jetting forward and there is compression between the hard pubic bone and the firm cervix that compresses the urethra, and patient will present with voiding difficulties. Voiding difficulties can range from a thin stream to anything up to acute urinary retention. Now, one more thing happens here. When the obstruction is not complete, which happens in most of these women, the residual urine remains every time when she pees. Urine tends to remain collected in the bladder, which leads to infection again and again, and this lady will present to you with recurrent episodes of urinary tract infection. Now, the doctor will treat this infection and it will subside. However, till the time you are not taking care of the cause which is actually leading to these recurrent infection, patient will not get relieved completely. Second kind of fibroids can be cervical fibroids. Actually, cervical fibroids in clinical practice are very, very rare to see. But if they are present with the same mechanism because of compression of bladder neck or urethra, they can also present with similar complaints which we just discussed about the voiding disorders. Third fibroids are either a single fibroid or multiple fibroids which increase the bulk or the size of the uterus. They compress upon the dome of the bladder, so the capacity of bladder is reduced. Little bit the bladder fills and the patient feels like going to pass urine. This causes frequency of urination and plus minus nocturia. Now the same kind of fibroids where the bulk is more and it crosses the pelvic cavity, the ureters might get kinked at the pelvic brim, which can lead to hydronephrosis and later on maybe pyelonephritis. So ureteric kinking will cause hydronephrosis. Now, last symptom which a fibroid can present as far as urogynecological or urinary issues are concerned, it can also cause stress urinary incontinence. If you go into PubMed, you will realize that there are many studies and we see in clinical practice also that fibroids associated with stress urinary incontinence. Though till date, we do not understand the exact mechanism that how this happens, but definitely there is increased predominance of these kind of symptoms or SUI symptoms in women who have fibroid versus who do not have fibroids. So today the case what we are going to discuss here is a lady who presented with mass per abdomen, but on further asking she agreed that actually she is having frequency and nocturia for many months. So we decided to do a myomectomy for her. Why myomectomy? Because patient was 36 years old, though she has already undergone 3 surgeries. Still, considering her age, we went ahead and did a myomectomy for her. Today, the same case we are going to show you step by step. As this lady has already undergone 3 surgeries before, opening of abdominal incision should be very, very careful. What you are seeing here, the red color structure, is the rectus sheath. And now, in between the 2 recti, we are trying to find a place to safely open the peritoneum. cases of previous pelvic surgeries, you must try to open the peritoneum at a point as high as possible because the bladder might be adherent to the lower peritoneum. So, when you come down, it is important that you open it layer by layer, checking the structure, what is there in every layer. And it's better to use knife rather than a cautery pen here, because if the bladder is just below that, there is a risk of bladder injury with the cautery. So the use of cautery should be minimal, and you must use cautery only once you know what is below this. So what we are cutting here is the fat, and we have confirmed that bladder is not adherent to this part of the peritoneum at least. Now, because of the adhesions and the muscle fibrosis, there is not enough space. So we decided to go ahead and put a Maylard's incision, which is a muscle cutting incision. Once you decide to convert your Fenton steel incision to a Maylard incision, the first step is identification of inferior epigastric blood vessels. And these blood vessels lie below the lateral edge of rectus abdominis muscle. So what you are seeing here is the inferior epigastric artery and the inferior epigastric vein. Now, with the help of two artery forceps, these blood vessels are caught carefully and cut in between the two artery forceps. Can you see the vessels clearly? Once it is cut, the two ends are tied separately with the help of a free tie. As far as the suture material used, you can use anything, whatever is available. It can be either a 2-0 vicryl or number 1 vicryl, the free end of it, or as we used on the other side, it can be a free tie with a silk suture also. Now, before you start cutting this muscle, always remember that the muscle should be supported with your finger. That means your finger should be below the entire extent of the muscle which you are going to cut. Use the coagulation mode of the cautery and just keep it with a very slow movement. You make a line on the muscle and you will see that the muscle will start cutting on its own. And what we are cutting here is the peritoneum. Again, check what is the content of this thickened peritoneum. Once you are sure, then only cut the peritoneum. Now the same procedure is repeated on the right side. First, look for the inferior epigastric blood vessels, and you got them here. Can you see it? The blue shining structure is the inferior epigastric blood vessel. Catch it with the help of two artery forceps. What I usually do is use three arteries. One to put below these vessels, open the space up, and then On top of that, put two arteries at a distance of around 1 to 2 centimeters and cut in between. You see, this is the artery which is opening the peritoneum. This is one extra safety measure we adopt while ligating this blood vessel. Now both these cut ends are tied separately, as I told you earlier, with the help of a free tie. Here what we are using is silk suture. Following this, we cut the belly of the rectus muscle, which is supported and lifted up with the index finger of the surgeon. When you use this monopolar cautery pen, go slow. As you move, the muscle belly will cut and the modus coagulation here, and it will get retracted on its own. Be slow and careful, especially at that area where the underlying omentum and peritoneum is stuck to the muscle. Cut it layer by layer. See what you are cutting. Once the abdomen is open, pull out the uterus to inspect and assess the number, size, and site of the fibroids. As you can see, it is a fundal fibroid. A bulldog is used at the top of this myoma to give good traction. As we are planning to give an elliptical incision, there is no use of wasting the hemostatic solution, that is vasopressin diluted in normal saline, at the top. So we give it where we plan to give the incision. An incision should not be too much at the base of the fibroid, because we want some flap or some tissue to cover the area or the bed from where we have removed the myoma. With the help of cautery again, this is the elliptical incision which is being given to remove the fibroid. We'll go all around like this. One point very interesting and very important is that whenever you are cutting the fibroid, don't just cut the capsule. Go a bit deeper onto the tissue of the myoma. It will decrease the bleeding and the enucleation will be much easier. Hold the myometrium, the normal myometrium, with the help of a few Alice forceps. And with just blunt dissection, you can remove this fibroid in totality. Whenever you feel the need, you can use scissors also to cut these fibers and nicely enucleate this fibroid. Once the fibroid has been removed, we hold the edges with the help of Alice forceps. It gives a bit of compression effect. In between, we see if there are any other fibroids which we have missed on the ultrasound. Once we have checked that there is no other fibroid that needs removal, we start closing the bed of the myoma. The suture material which we are using here to approximate the myoma bed is number 1 Vicryl. And the technique of suturing is continuous and locking. Locking for hemostasis. Now, the purpose of this layer are two. One is to create the hemostasis, and the second one is to close the dead space. As I keep on telling always, that if you want to prevent a hematoma, these two things should be in your mind: perfect hemostasis and closure of all the dead space. And this is the last bite of the first layer. For the second layer of closure, we use Vicryl 2O, and the technique of closure is called baseball suturing. The idea is that the knot should be inside so that there is no tissue outside which might promote adhesions. The edges should be buried inside. That is the first thing we have to remember. Then we start the baseball suturing. And baseball suturing is simple. You just have to go at every bit from inside to outside. The advantage of these baseball sutures is that it gives a perfect approximation of the two edges. So, the lower surface, inside to outside. See that the suture is not locked. Take another bite from the other side, again inside out. Keep on doing this for a perfect approximation of the two edges. Once more, let me repeat it for you. Upper edge, inside out. Tighten this suture material. Change the direction of the needle, and from the other edge again inside out. And tighten it once more. Hold the margin. With your needle, go inside out. The assistant will tighten the suture for you. You change the direction of the needle in that time. Hold the other edge with the help of a tooth forceps. Go again from inside out. And tighten this suture also. Now, as we realize that the distance here was a bit more between the two edges, so we decided to take another bite, a figure of 8, to reinforce the first layer. You can improvise on any time, whenever you feel like. Only thing, you should know why you are doing what you are doing. After this, we come back to the second layer which we have left in between and start it again. Inside out and inside out. That is the baseball suture. I am showing you the entire suturing so that it gets imprinted on your minds. Now we have reached the end of the incision and you can see a bit of redundant flap. If you just suture it the same way in a linear fashion, what you will have at the end of the surgery is a beak-like projection which will invite infection and adhesions. So we'll bury it. To bury this protruding edge inside, take a bite from this and then take a few bites in reverse direction at the suture line. Pull it tight and then put a knot. See how nicely it has got inverted inside without leaving any raw area on the top. So this is the final result, what you see here, and it looks perfect to me. The incision is closed in a vertical fashion. And to take care of a bit of hemostasis now, you can use the monopolar cautery in coagulation mode. And we are done. I hope it was of help for the beginners. Thank you.